Hello guys, welcome back to Clinically Clear. So today we'll be covering another important topic, that is allergic rhinitis. So allergic rhinitis, it is of course an allergy, right? So it is a type 1 IgE mediated hypersensitivity reaction to towards airborne allergens in the nasal mucosa. Rhinitis, so inflammation of the nasal mucosa. Why is there inflammation? Because of a type 1 IgE mediated hypersensitivity reaction. We know that it is an allergy, so it is because of allergens, and usually in the nasal mucosa, meaning it will be airborne allergens. Etiology, usually allergies always have a genetic predisposition, like some family history of allergy, parents have asthma, you have eczema, asthma, allergic dermatitis, etc., etc. Some genetic predisposition. Then the allergen itself is a cause. You can have seasonal allergens like pollen grains. You can have perennial allergens like dust, mold, animal dander, cockroaches, etc. Then coming to the pathology. Basically, what happens first, there is sensitization. The allergen induces IgE antibody synthesis. This IgE antibody synthesis, they go and coat the mast cell. This mast cell is said to be sensitized. Once sensitization of the mast cell takes place, two things happen. These two things constitute something known as priming. In priming, you have two things. First is the mast cells, they become so reactive that even a small dose of allergen is enough. They become reactive to subsequent lower doses of allergen. Enough. Second thing is the mucosa becomes non-specifically hyperreactive. That is, not just to the allergen, but even reactive towards non-specific stimuli like stress, smoking, pollution, weather changes, etc. So this is what in priming. So lower dose of allergen, subsequent exposure is enough, as well as non-specific hyperreactivity to non-specific stimuli. Then what happens? You have re-exposure where either the allergen or these non-specific stimuli, they cause, and then the nasal, they are exposed, and then the nasal mucosa reacts. How does it react? Through mast cell degranulation. This mast cell degranulation occurs in two phases, an early phase and a late phase. An early phase, it occurs within half an hour, and there is release of preformed inflammatory mediators like histamine, heparin, which can cause vasodilation, bronchospasm. Then you have eosinophilic chemotactic factor A, neutrophilic chemotactic factor A, etc., which cause chemotaxis. They attract more and more WBCs. Then you have, what are the symptoms? In this early phase, within that half an hour, as soon as you're exposed to the allergen, that is when you have those typical allergic symptoms like watery discharge, sneezing, nose block, irritation, itching, bronchospasm, difficulty in breathing, stuff like that. Then what happens? Eventually, the mast cells, they start freshly preparing mediators and and they start to release it. This occurs after about 8 hours, like within 8 hours, but after a significant duration. It does not occur immediately. These mediators, like prostaglandins and leukotrienes, they cause inflammation, congestion, edema. So the edema, the congestion, most important is edema. All is because of the late release of freshly prepared inflammatory mediators. So this is about the pathophysiology of how the hypersensitivity reaction occurs, leading to inflammation of the mucosa. Then clinically, you have two types of allergic rhinitis, that is seasonal versus perennial. Seasonal allergic rhinitis is due to seasonal allergens like pollen grains. Here, the symptoms are more severe, more acute, but self-limiting. They'll resolve on their own. They'll keep coming again and again, but they're like very, very intense and acute. Example, as soon as you're exposed to the allergen, you start having watery nasal discharge, you start sneezing, you start itching, you start having bronchospasm, you get a nose block, nasal obstruction. Whereas perennial allergic rhinitis, the symptoms are more persistent, they are constant, but less severe. Example, they keep getting upper respiratory tract infections, keep getting rhinitis, sinusitis. They feel constant stuffiness in the nose. So these are the symptoms of the two types based on the occurrence. Then coming to the signs. Now, signs of allergy you can have in various regions. First, let's look at the nose. Number one, as I told, edema will be there. With edema, you will have turbinate hypertrophy, you will have serous nasal discharge, and you'll have something known as allergic salute. What is allergic salute? Basically, patient, because of the continuous nasal discharge, the itching and the irritation, patient keeps rubbing their nose upwards like this. This leads to a black transverse crease. As you can see, hyperpigmented transverse crease on the nose. Transverse hyperpigmented crease on the nose known as allergic salute. So, 4 nasal signs: allergic salute, edematous mucosa, turbinate hypertrophy, serous nasal discharge. Then you have ocular signs. In the eye, again, edema of the eyelids. Edema, you should note that, common thing. Then conjunctival congestion occurs. Think of stuff you've also read in allergic conjunctivitis. Conjunctival congestion occurs. Then something known as allergic shyness. As you can see, this hyperpigmented patch beneath the lower eyelid, this is allergic shyness. This is known as allergic shyness. Then otological signs in the ear. What happens is, because of all this discharge, nasal obstruction, edema, turbinate hypertrophy, the opening of the eustachian tube gets blocked. So the eustachian tube dysfunction occurs. When that happens, obviously there is no pressure equalization. So the air pressure from here pushes the tympanic membrane inwards, retraction of the tympanic membrane. And because of the blockage of eustachian tube, there is secretion accumulates, there is no drainage. This causes serous otitis media. There is no infection. I repeat. It is because of inflammation causing blockage and then dysfunction. So it is not suppurative otitis media, it is serous otitis media. You have clear jelly-like fluid. Then in the pharynx, you have lymphoid hyperplasia that causes granular pharyngitis. Important. Whereas in the larynx, again, edema. The edema causes inflammation there, making it difficult to speak, hoarseness of the voice. So these are all the signs. So ocular signs: allergic shyness, congestion, edema of the eyelids. Larynx, hoarseness, edema. Pharynx, granular pharyngitis due to lymphoid hyperplasia. Otological signs: retraction of the tympanic membrane and serous otitis media because of eustachian tube dysfunction. Then coming to the classification of allergic conjunctivitis, allergic rhinitis, not conjunctivitis, allergic rhinitis. So seasonal versus perennial, I discussed above. There is another classification known as area classification, allergic rhinitis and its impact on asthma. Now, based on duration, you can classify it into intermittent allergic rhinitis and persistent allergic rhinitis. Symptoms: less than 4 times a week or totally for less than 4 weeks, intermittent. Same thing, more than 4 times a week or for more than 4 weeks, persistent allergic rhinitis. Then let's come to the severity. You have mild allergic rhinitis, moderate allergic rhinitis, and severe allergic rhinitis. Mild will cause no disturbance to sleep or any daily activity. Moderate and severe will cause disturbances. So that is why, based on severity, you have mild, moderate, and severe. So seasonal versus perennial and area classification, allergic rhinitis impact on asthma. Based on duration, less than 4 weeks or less than 4 times a week. Then intermittent allergic rhinitis, more than 4 times a week or more than 4 weeks. Then persistent allergic rhinitis, based on severity, mild, moderate, and severe. Then let's go to the diagnosis. Now, diagnosis, see here I've written very, very long, but just basic things you need to remember is, you'll take the nasal mucosal smear. When the patient is having symptoms, when the patient is clinically active, what will you see? You'll see a lot of eosinophils, eosinophilia. Always allergy is associated with eosinophilia. But eosinophilia is non-specific. Just because you see eosinophilia, it does not mean it is allergic rhinitis. There is something known as NARS, non-allergic rhinitis with eosinophilia syndrome. You have to be aware of that. Then you can check total serum Ig, that will increase. Allergen specific serum Ig, that will also increase. This is more specific than total serum Ig. Then you can do nasal provocation test, where you'll take a toothpick, you'll put an allergen on the tip of the toothpick and you'll make the patient sniff it. When the patient sniffs it, patient suddenly starts getting symptoms. That is nasal provocation test. Then you have skin prick test, where you'll put an intradermal injection of the allergen. Then you'll check for wheal and flare response. These are all some tests. So DLC to check for eosinophilia, but non-specific. Remember, NARS can also have eosinophilia. Then you'll check serum Ig, you'll do nasal provocation, you'll do skin prick test. Then coming to the treatment. See, treatment, best, most effective treatment is avoidance of allergen. Just avoid the allergen, avoid exposure to pollen grains, avoid exposure to dust or animal dander, etc. Medical treatment, you will give all the anti-allergic medications or stuff that causes symptomatic relief. Antihistamines obviously will prefer second generation like fexofenadine and ebastine over first generation like cinnarizine because of drowsiness. You'll prefer, and then you can give the nasal decongestants which cause vasoconstriction, reduce the amount of discharge, make the airway clear. Topical like oxymetazoline, xylometazoline. Oral like phenylephrine and pseudoephedrine. Then steroids also. Steroids only for a short duration, not long course because of side effects. So you can give intranasal steroids like mometasone, budesonide, oral steroids like prednisolone. Then you can give intranasal ipratropium bromide, mast cell stabilizers like sodium chromoglycate, ketotifen, leukotriene antagonists like montelukast, zefirlukast, omalizumab, which is an anti-IgE monoclonal antibody. So that is some medical treatment. And another way to like completely reverse your allergic rhinitis is by something known as desensitization therapy, which is more and more popular these days. What they do here is they gradually introduce the allergen into the patient in slowly increasing doses. So eventually what happens against this allergen, the patient in the patient's body, the antibody class switches from IgE to IgG. So then what happens? There is no longer mast cell sensitive. There is no longer mast cell coating. So the mast cell degranulation will also stop. So that is desensitization therapy. So avoidance, medical management where you'll give steroids, ipratropium bromide, leukotriene antagonists, omalizumab, decongestants, antihistamines, etc. for symptomatic relief and anti-allergic effects, and desensitization therapy. Symptoms, complications. Polyp, more importantly, bilateral ethmoidal polyp is due to allergic rhinitis. Then sinusitis, because patient is having continuous edema of the mucosa, that can predispose to secondary bacterial infection leading to sinusitis. Then patient already has predisposition to allergy. So because of that, again patient from upper respiratory tract infection, allergic rhinitis is a URTI allergy. It can go into LRTI. Then dental problems because patient keeps breathing through the mouth. And as I told, one of the otological signs, serous otitis media. Why? Because of eustachian tube dysfunction. So complications not that important, but remember just 2-3 so that you can write in case they ask. So that's it for allergic rhinitis, short topic. Thank you for watching.